And so in spirit of keeping us on schedule, but also making sure that there is enough time for questions, our last two speakers have agreed to switch order. So it's actually going to be Commissioner White coming out, and then at the very end it'll be Dr. Clancy. So I'm very pleased to introduce Commissioner White.
Well, good afternoon. Thank you for being here this afternoon. Thank you for having me. So, as you heard earlier in the introductions, I'm the Commissioner of Mental Health and Substance Abuse Services for the state of Oklahoma. This is my 12th year as Commissioner, but I'm a social worker by training. So I'm sandwiched in with 3 amazing MD psychiatrists, and that means a lot of heavy technical information. So I'm not going to use slides. I'm going to talk to you today. We're going to have a conversation, and we're going to have a conversation kind of as lay people, because I think, given my 2 topics, which are substance abuse and public health, I think it's going to be really important we kind of step back and have that conversation. So the first thing that I want to talk to you about is to make sure that we all are understanding that there is a real difference in dialogue about what we're having here about cannabis products that contain CBD. So CBD, like the question the woman asked, and when you're up here you can't see very well, so I'm not pointing exactly at you if you're still here, but kind of your general direction, because I can barely see you all with the lights. But asked a question about CBD and the benefits that she'd seen of CBD versus THC, because these are 2 components in the plant, a plant that has like 400 components, right? And we actually know very little about most of the components. But I think it's really important as we talk about substance abuse and about public health that we separate these 2. And you heard Dr. Beeman talk about it a minute ago. You've heard different speakers touch on it. CBD is the portion of the plant that is non-intoxicating. It's non-intoxicating. This is the portion of the plant that there may be some benefit around sleep, as we heard earlier, around pain, as we heard earlier, around anxiety and other things. And there aren't, as you heard Dr. Beeman answer earlier, there aren't any studies that show using CBD has negative effects. And then there's THC. THC is the portion of the plant that is intoxicating. THC is the portion of the plant that's associated with the negative things you've been hearing earlier, the onset of psychosis and other things that increase in suicidal thoughts, which we know we don't need in Oklahoma, having one of the highest rates of suicide already. So those components can easily be separated. But when we're having these public discussions as we talk about public health, we're not really being always clear, and we're trying to be clear here today, but we're not always clear, and I don't think the public's really clear on the difference between those 2 things. And so I think that's an important piece of the discussion. So as we move into substance abuse first, which I'm going to talk about, high-content THC, products that have high-content THC, the intoxicating part, the part that causes the negative effects that we've been talking about. High-content THC, or the higher, and I shouldn't just say high-content, the higher you go with your THC content, the more likely you are to have a first need for substance abuse dependent treatment. The higher the content of your THC, the increase the severity is of the marijuana disorder, addiction, and dependence. And make no mistake, THC is absolutely addictive for some people. Absolutely addictive for some people, and I'm going to talk more about that in just a second. So CBD has not been shown to be addictive. It's non-intoxicating. But THC absolutely can be and is for many Oklahomans already. And so in separating those 2 things, I think, are a really important piece of the discussion. The second piece as we talk about substance abuse is the discussion about how often THC is used. So a lot of times we just say marijuana, and with marijuana you do have the THC in it. But I'm not talking about how often you use CBD when I'm talking about this. But the more often you use marijuana with THC in it, or any product with THC in it, the more often you use it, the more likely you are to become addicted. And there is a real difference in marijuana and THC users. Some users use it occasionally, and some users are daily or near daily users. And it makes a big difference in some of the outcomes that I'm talking about as it relates to substance abuse. And so, for example, daily or near daily use of marijuana, THC for those who use it, is at its highest level since the early 1980s, which was the highest previously recorded level for our college-age youth. We have much higher levels of daily or near daily use of THC among our college students. Daily or near daily use of THC and marijuana is up all ages all age groups, their daily or near daily use of marijuana, if they use, has gone up about 50%. It has doubled since 2002. When you look at marijuana users, more than 2 in 5, almost 2.5, so about half of all marijuana users are daily or near daily users, which means the other half are not near daily or daily users. So what does that mean? And they told me I could move around. Plus, we're after lunch, and I know you guys are getting tired. So one of the things I think sometimes if I can shake it up, maybe you'll pay better attention. So we're going to separate the room in half for just a second. And so this half of the room, you guys are not going to be daily or near daily users. You use marijuana, and you use THC, but you use it occasionally. So your addiction rate, very clearly for THC, if you're not a daily or near daily user, your addiction rate is about 9%. And when I say this, sometimes I say only 9%, and then I catch myself. And I'm like, well, 9% still matters. But just remember, you don't use daily THC, so you're at about 9%. Now, other half of the room, and I'm gonna be with you guys, I'll put myself in your group. We are marijuana users, and we use it daily or near daily, okay? We are daily or near daily users of THC. Do you know what our addiction rate is? In study after study, it's somewhere between 25% and 50%. And most studies show that it hovers around 40%. So how often you use marijuana and how often you use THC really matters. Daily or near daily users have a much higher addiction rate to THC. Their addiction chemistry in their brain is much more likely to come on. So the other thing that matters in this discussion about addiction as it relates to THC is how old our brain is. And if you've heard me talk before, and unfortunately for some of you, you're like, yeah, I've heard you talk many times, right? But if you've heard me talk before, one of the things I talk about a lot is that the prefrontal cortex of the brain is the very last part of the brain to really finish developing. Now, our brain grows and changes our whole life. But the prefrontal cortex is where all of our executive functions are housed, our clinical thinking, our judgment, our logic. And the majority of the development of our prefrontal cortex finishes between the age of 20 and 25. And if we use addictive substances before our prefrontal cortex is developed, our brain is much more likely to chemically lock onto that substance. If we wait and use addictive substances after our prefrontal cortex is fully developed, our brain is much less likely to lock on and become addicted to that substance. There are actually protective that happen. I think I'm moving on them and throwing them off with the mic, sorry. There are actually protective factors that happen in the development of the prefrontal cortex that if you use addictive substances after it's developed for the first time, your addiction circuitry is much less likely to come on. That's why when we talk about alcohol use in our kids who use alcohol for the first time before their prefrontal cortex is developed, so say age 15, are 6 times more likely to become dependent and lock onto that alcohol than youth who wait to the age of 21. So as we talk about addiction as it relates to marijuana and THC, how often we use, no matter our age, whether we're in the daily or near daily group versus occasionally, and the age of the brain make a significant difference. So I want you to remember that as we talk about addiction. The other piece that I'm supposed to talk about today is public health. And as we talk about public health, I think one of the most important things to think about, and for those of you that aren't really familiar with public health means how we protect the public. So some examples of important public health legislation in the last 50 years. Seatbelts, one of the most important public health laws we have, requiring people to wear seatbelts. Preventing youth from drinking alcohol, setting the drinking age at 21, one of the most important public health pieces we have. All kinds of issues, regulating restaurants, food safety. You heard earlier one of the speakers talking about that cannabis and marijuana are unlike other medical products. Some medical products are, but unlike other medical products, can grow mold and other things, and how are you going to handle contamination? So those are considerations when we talk about public health. When we talk about public health, we have to think about smoking in public places, right? Oklahoma, as we know, was a late comer to the game of saying we don't have smoking in public places because of the public health risks, but we know that's an important piece. So as we talk about public health as it relates to THC, to marijuana, to CBD, to all of these products, one of the things that I think is really important, if we go on the micro level of public health, is knowing what we know about the age of the brain and that if we're younger when we use this product, we're more likely to become addicted. How are we going to create public health laws or regulations that protect our kids? One, we should not have packaging that's attractive to kids. There should be no cartoon characters. There should not be slogans and advertisements with things that are bright colored and those types of things that really appeal to kids, right? As adults, we're kind of boring. And we'll read labels and we'll still buy things if it's in a plain black and white package. So I think making sure that we don't market or have things that are attractive to kids becomes really important. Are we going to have a symbol on the package that lets people know there's actually THC in it? We should have a universal symbol, if we're talking about public health, that when you see that symbol, and it can't be the symbol we have now, because the symbol we have now, right across the state that you've seen popping up almost on every street corner, the green kind of cross-looking symbol, none of us know if that means CBD or THC or marijuana, right? So what's going to be the universal symbol for the addictive product of this, the THC? Because that needs to be in there. Because here's the thing, we heard the question earlier was such a good question because it was about a much older Oklahoman, or maybe she wasn't living in Oklahoma, I wasn't sure by the question, who was using CBD, the non-intoxicating part. Well, if you were living in Oklahoma 6 months ago and had access to CBD, or 8 months ago, what if now all of a sudden your product has THC in it and it's intoxicating and you don't even know it because there's no universal symbol and it's not labeled? So when we talk about public health, that's another really important piece. The other thing we've got to put on these labels, what's the concentration of THC in the product versus the concentration of CBD? CBD not intoxicating, the positive effects we were talking about earlier, should be high, right? THC, the higher you get, the more likely you are to have all those negative consequences we just talked about, including addiction, should be low. But we don't even have a requirement in our state right now, like most states do, to say, we're going to at least tell you the percent of THC and CBD in the product that you're looking at. That's got to be an important piece of public health. For the public wants to take responsibility for their health, and they should, but they have to be given the information about what's in the product they're looking at. Advertising. One of the biggest things for advertising, and when you talk about public health, is how you advertise, where you advertise. First, not advertising for products. Let's talk about alcohol for a second, just so you see what I mean. Alcohol advertisements shouldn't be targeted at 15-year-olds, right? They should be targeted at adults. We've got to make sure that our advertising for this, knowing what we know about young brains, isn't targeted at kids. And as importantly, if not more importantly, we cannot have false information in our advertising. We should be required, just like we are with any other medical product, to have to put true information. You heard Dr. Beeman talking earlier, and I thought one of the most important points he made. For a state that is already overrun with opioid overdoses, although we are making progress and we are moving down the ladder, which is great, the fact is that the research is pretty clear that use of THC increases the likelihood that you will have the subsequent onset of an opioid use disorder. So when we market things, are we telling the truth in the advertising or not? That becomes a really important piece of public health discussion. And finally, on public health, in terms of one of the things that needs to happen is a public health information campaign. Everybody in Oklahoma, and I say everybody, not everyone, but so many Oklahomans are darn confused right now about what's going on. And with other things, there are public health campaigns and information campaigns that share that information. So people know about the discussion we just had about CBD versus THC. All of that information, because everybody's shelves are changing right now. And the public is not getting good information or being educated about it, and that has to happen if we're talking about public health. So the last thing that I want to say as I talk about public health, and then I'm happy to take any questions, is that public health also happens out of the state capitol. And right now, because you've heard several speakers allude to it, but I don't know if anybody was really clear with you about what this means. So the state question passed. And what that means is that the contents of the state question are now in state statute. What is happening right now at the Capitol, and if you followed any of the lots of things that were happening over the summer with these rules and regulations and what was in statute, what was in rules, there was a whole lot of discussion about what public health measures could be instituted given the way the state question was written, and it's not very many, given the way the state question was written. But what was clear and what the Attorney General has said is that the statute absolutely can be changed. And right now, what the legislature is considering is, what should that statute look like? And anything can be on the table. Now, do I think that they're going to change it and that we're not going to have marijuana in the state? Absolutely not. That is not going to happen. It passed overwhelmingly. But what is happening right now, and if you haven't followed this, is that the marijuana industry, the growers, the sellers, the dispensaries, they have gotten together in a pretty big group, and they've developed a bill that's about 250, maybe more pages of what they want the statute to look like. Okay? And there are some things in that bill that I think all of us can agree with. But it's also written from that perspective. And one of the things that as those of us that work in public health, in the medical community, in mental health, in substance abuse, are saying, and I think is an important discussion to have, is what else should be in that legislation to protect public health and to decrease the chances that we're going to have people using high-content THC with low-content CBD? What should be in there to address those issues and to try to prevent addiction and to prevent an increase in people thinking about suicide or attempting suicide, and to try to do all of those things? And so I think it's really critical that if this is an issue you care about, that you realize it's here to stay. I really believe that. But that right now is when the real skeleton is going to be built of what this is going to look like in our state. And in Oklahoma right now, we are the Wild West when it comes to medical marijuana. There is no other state that has a law like this. There is no other state that doesn't have some form of public health regulation in their statute. And we really have to remember that if we're a state that cares about the health of our people, and I know that we are, that we're going to ensure there is some balance between how we do this to both protect public health, increase access to CBD, decrease access to THC, and make sure that we approach this from a perspective, from my position of what we're talking about, that prevents addiction and increases public health. Thank you very much. I just gave you back so much time.
I really appreciate it.
Physicians always talk longer. Now, I know Dr. Clancy won't because he's a rock star, but we were talking backstage and he said, everybody's going longer. I said, I'll make up the time. So there you go.
Much obliged. Okay, questions?
Thank you. This is an opinion question. Why do you think our government is so much more interested in controlling cannabis than it is alcohol?
Well, so part of this, I'm going to ask you a question back. I'm curious why you think the government is our government. And first of all, I can't answer for government. I am not a legislator. I'm not the governor. So I don't get to make laws, right? That's not how this works. So I'm curious why you think that what perspective it comes from. I know it's the topic right now, but we have by far hundreds more statutes on alcohol than we have on cannabis. So I'm not sure I understand the question of what makes you think the government is more interested in regulating cannabis than alcohol right now. And I'm not saying you're wrong. Please don't misunderstand me. I just am not sure I understand the question.
It was my understanding from earlier presentations that research is being limited by the government by making it
a Schedule I drug.
Schedule I drug.
So what you're talking about is that the federal government has it as Schedule I drug. I really don't know how to answer you why the federal government has it as a Schedule I drug, only in the sense that I am a state official and my career is working at the state level. So that would be like, if I turned around, if you all, I'm going to assume for 1 second you all live in Tulsa, and I'd say to you today, hey, why is Oklahoma City doing this? I don't know how to answer the question for you about what the federal government does, but I understand what you're saying about Schedule I drugs and research. Yes, ma'am.
Excuse me, we have a question over here.
Oh, sorry.
Right over here.
It's really hard to see up here.
You present information about cannabis.
Are you talking about CBD or THC or both?
Both.
Okay.
You know, a lot of the presentations kind of said cannabis as if it was all one thing.
Right, that's the part I'm trying to
Which is
say.
unfortunate.
Right.
And the scheduling actually happened when Nixon, by executive order, went against the doctors in 1970, against the Schaefer Commission. So I think the question we're trying to ask is, you know, Dr. Beeman wanted more control, but the physicians have given up control because they have never gone up and said, you know, why is Nixon deciding that this should be Schedule I? If you looked at the actual harm versus the potential benefits,
So
I
tell me
can't
what your
understand
question is of me. I'm so sorry.
you know what, because you're,
What are you, what is it you're asking me?
right, I think that all of us have a responsibility, whether we're a state employee or a legislator or a patient, to go further than just, well, I don't know. I'm not involved with the federal government. I don't know why they're scheduling Schedule I. You know, here methamphetamine being Scheduled II and cannabis I, I'm like, we have a responsibility to take care of that.
I
And so that's- I
understand what you're
apologize.
saying, but I'm not going to be able to answer for the federal government here today. I'm sorry, I
Right,
just
but
can't.
some of the physicians have said, well, the federal government says it's Schedule I, so we can't study it, and that absolves me of having to even consider prescribing it.
I thought what I heard here today was a lot of people talking about the need to be able to do more research, but I can't answer for anyone else, and I can't answer for the federal government. It is a Schedule I drug, and I'm happy to talk to you about anything related to Oklahoma public health or Oklahoma substance abuse today.
We have a question over here. I'm also just going to make one quick comment in terms of the concept of drugs of abuse that are on a different schedule. Is really intended at a federal level to try to prevent harm to the population. And that if you look at the way that drugs are currently scheduled, you can see a number of other drugs for which there's actually research happening. This is the Cannabis Summit, but there's actually research happening on other substances looking at potential salutary effects. For example, in psychiatry, you know, depression is a big problem and suicide, and ketamine, which is a Schedule III drug, is currently a hot topic. A lot of people, there are a lot of actual randomized trials that are emerging suggesting some positive effects on suicidality in that particular substance. So I think ultimately what we need is better research, and we need the ability to do that research. And whether it happens in this country or whether it happens sort of in other countries, ultimately we do need sort of those highest quality markers of evidence.
Yeah,
So,
we have to be doing evidence-based medicine, and certainly as it relates to state resources, we have to be spending dollars on practices we know that are cost-effective and have good outcomes. Medicine is a science. I mean, we should be using evidence-based services. I say this all the time, particularly in the world of mental health and substance abuse, where there's so much stigma and confusion about what these brain diseases really are. There is a whole lot of very clear evidence and medical science, and that's what we should be utilizing as treatments as it relates to mental health and substance abuse. Yes, sir?
Yeah, so I think we have a unique opportunity. I mean, we talked about the different levels of evidence, but we have a unique opportunity now that legal status has changed. There will be possibly different patterns of use. Are you looking at it from a state side to monitor mental health and substance use problems sort of pre-post? And looking at what changes you're seeing? And
we're looking at everything what we're going to need to monitor in the state, and for our stuff that will be easy because we have a really good public mental health and substance abuse data system. We actually have one of the best in the United States. But there are definitely gaps, you've heard some today, of other data collections in the state that, for example, if this information going to be, are we going to know, is this collected? And so to do health research, we need to be very comprehensive. But one of the things we're also doing is we're watching a lot of the clinical trials that do exist. There's a trial right now in New Mexico, because one of the things I kept hearing over the last several months is we need this for PTSD. Well, again, CBD has potential for a lot of positive effects. THC has a lot of negative effects. There is no evidence that THC is at all good for PTSD. We know it increases anxiety. So it's very concerning to look at what might happen as it relates to PTSD, but there's a really good, big study happening in New Mexico right now that everybody's sort of waiting on the edge of their seat, and it's actually targeted at veterans. And so we're very anxious to see what the outcome is so that we can base our recommendations and our medicine on that. If it shows it has positive effects, we need to know it. If it shows it has negative effects and exacerbates symptoms, we need to know it. And so we definitely need more very clear research.
Okay, I think it's 3:05, so just, do you want to take another
I will
question?
take one more question.
Okay, this woman over here had raised her hand earlier. Do you still have a question?
I just want to thank you. I want to thank you for the courage to be present. I want to thank you, Dr. Clancy, for the courage to address this topic. I want to thank you, LIBOR. I want to thank you, Warren Foundation. I want to thank you, Laureate. I want to thank you, TU. I want to thank you, OU. It's with gratitude that we're all here. Thank you, Terri.
Oh,
Well, thank you. No question there, but we'll allow it. Okay, it's my pleasure to introduce